Welcome back guys. Now in this video let's discuss about vascular physiology. Okay. Now in this vascular physiology we are going to mainly concentrate on the blood vessels. Okay. Mainly we are going to concentrate on blood vessels. See, the first blood vessel which I am going to discuss here is aorta. Okay. Now we are going to go in a sequence. Aorta, arteries, arterioles, capillaries, venules, veins, something like that. Okay. Lymphatics, something like that. So the first blood vessel which I am going to discuss about the important points about the aorta. Okay. Now aorta is the one blood vessel which is having a nature called as a Wind-Kessel effect. Aorta is having which property? Wind-Kessel effect. If you ask me what exactly is this Wind-Kessel effect, sir, it's the elastic recoil nature of a blood vessel. Okay, it's the elastic recoil nature of a blood vessel after stretching. See, aorta, when heart contracts, aorta is going to receive the blood. So when it is receiving the blood, it is going to stretch. And what happens? Later on, it will again collapse back, it will recoil back, pushing the blood forward into the systemic circulation. So aorta is the one blood vessel which will stretch and undergo elastic recoiling. Stretch and undergoes elastic recoiling. So aorta is the one blood vessel which show an effect called as a Wind-Kessel effect. So what exactly is Wind-Kessel effect? Wind-Kessel effect is elastic recoil nature of a blood vessel is called as Wind-Kessel effect. And direct question that will come in your exam is Wind-Kessel effect is shown by which blood vessel? Aorta. Now aorta is having maximum BP. Okay. Maximum BP is seen in aorta. See, when we say the blood pressure 120 by 80, see this 120 by 80 is going to be seen in the major blood vessels. Okay, aorta, brachial artery, like ulnar artery, radial artery. See, the BP is going to be, we are going to measure the BP mainly in the major arteries. Do you think same 120 by 80 mmHg pressure is going to be there in the capillary of a conjunctiva? See, whenever you see the conjunctiva, you are seeing so many capillaries, right? Do you think the blood pressure is going to be 120 by 80 in all these capillaries? Never, never. So maximum amount of blood pressure is seen in the major arteries, that to aorta. Okay, because it is very near to the heart. Okay, it is very near to the heart. So if the heart is generating 120 mmHg pressure, all that 120 mmHg pressure is going to communicate into the aorta. So aortic pressure increases. If heart is generating 150 mmHg pressure, all that 150 mmHg pressure is going to now come into the aorta. So aorta have 150 mmHg systolic blood pressure. So at the end of the day, the maximum BP is seen with the aorta, is there in the aorta, and the minimum BP is seen in the vena cava. Okay, the minimum BP is seen in the vena cava, especially in the point where it's entering into the right atrium. Okay, it's the point where it's entering into the right atrium. It's having the minimum blood pressure. Now most of the student doesn't even know, why do we need the blood pressure? See, normally whenever there is a proper blood pressure, then only the blood is under, the blood is kept on now circulating. For example, now think like something like this. At heart, in the aorta, the blood pressure is, let's take the mean arterial blood pressure. What is the mean arterial blood pressure? The mean arterial pressure is somewhere around 93 mmHg. Okay, now here it is 93 mmHg. Now in the tip of my toe, do you think the same 93 mmHg will be there? No. Here it is 93 mmHg. The tip of my toe, it will be somewhere around 10 mmHg only. Okay. The capillaries and the venules and veins over there, it's just only 10 mmHg. So blood is moving from high pressure to low pressure. Simple. And now if you want to have a venous return, now how much should be the pressure in the right atria? In the right atria, in the vena cava, the pressure is almost 0. So blood is now going to move from 10 mmHg to 0. So high to low. So whenever you have a proper blood pressure, then only you will have the blood in circulation. Okay. Now maximum BP is seen with the aorta, minimum BP is seen in the vena cava. Okay. Next, where do you have the maximum turbulence of the blood? Okay, in the aorta you have the maximum turbulence of the blood. The maximum turbulence is seen. Okay. Now after that, see, this aorta is having the least cross-sectional area, so it's having the maximum velocity. Now already we have discussed the maximum turbulence is there, and in the aorta the blood is moving very, very fastly. So maximum velocity is seen. Now if you ask me why there is maximum velocity, why? Because it's having the least cross-sectional area. Later on in the next slide I will show you. See, aorta is having, see, least cross-sectional area. Here I am showing you, here in this graph I am showing the cross-sectional area. The cross-sectional area of aorta is least. So whenever the cross-sectional area is less, okay, in the aorta the cross-sectional area is less. But what about the velocity? Velocity is more. Okay, velocity is more. Now when velocity, here the velocity is decreasing. But in the aorta the velocity is more. But what about the cross-sectional area? Cross-sectional area is less. Okay, the cross-sectional area is less. So think something like this. Now whenever you squeeze a garden hose, okay, whenever you squeeze a pipe, okay, rubber pipe, what happens? What happened to the velocity of blood flowing through that pipe? Okay, just imagine that there is a rubber pipe or garden hose, okay, through which the water is coming out. Now you just compress the tip. So what exactly you are doing? You are compressing, you are decreasing the surface area. Whenever you decrease the surface area, what happens? Water will come with more velocity. So in the same way, what I am trying to put into your mind is, so whenever there is less cross-sectional area, there will be more velocity. Okay, so aorta is having minimum cross-sectional area, least cross-sectional area, so it's having the maximum velocity of the blood flow. Now, already I have explained to you the capillaries. See, capillaries have maximum cross-sectional area. If you look at here, see the capillaries, they are having, see these are the capillaries. Capillaries are having the maximum cross-sectional area. Okay. Now, usually students will think, sir, capillaries are very, very small blood vessels. Now, how come they have the maximum cross-sectional area? See, you are having only one aorta, but you are having millions and billions of capillaries. Okay, you are having billions of capillaries. So, we are taking all the capillaries into account. So, when you take all the capillaries into account, now they will be having more cross-sectional area. Whenever there is more cross-sectional area, now what happens? Blood flow is going to be decreased, or the velocity of the blood flow, the velocity, okay, I should say the velocity of the blood flow is very, very minimal. Very means very, very slow, very, very slow. Is that good or not? Is that definitely good? It's definitely good. Why? Because whenever the blood is going with very less speed, exchange of materials happens more in a more in a more better way. Okay, now whenever the velocity of blood is slow, now the gases exchange, waste product exchange, the hormonal exchange, nutrient exchange is going to happen in a very better way. So please concentrate here, guys. Capillaries have the maximum cross sectional area. So what happened to the blood flow? The blood flow is having the least velocity. Now here I just want to discuss some important points about the aorta, which are just clinical integrations. See, aorta is going to have a tree barking appearance in a disease called as a tertiary syphilis. There is a disease called as tertiary syphilis, okay, which is also called as, sometimes called as a neurosyphilis. Okay, the tertiary syphilis, which is also a neurosyphilis. Now in this neurosyphilis, central nervous system is going to be affected, as well as heart is going to be affected, especially the aorta. After the death of the person, if you look at the, if you do the post-mortem and if you look at the aorta, okay, now the wall of aorta, it looks like a tree bark. This is called as a tree barking appearance. So tree barking appearance of the aorta is seen in which condition? Tertiary syphilis. If you want to know some more important points, syphilis is what kind of infection? It is a sexually transmitted disease. It's a sexually transmitted disease. Now syphilis is because of the which agent? What is the causative agent? The causative agent is Treponema pallidum. Okay, Treponema pallidum. Okay, T pallidum, which is a spirochete. Okay, which is a spirochete, the spiral shaped organism, which is a spirochete, the spiral shaped organism. Now some important points about the spirochetes which were recently asked in the exam. Okay, just recently asked in the exam, that's why I am trying to integrate. The spirochetes are going to be visualized specially with the help of a microscopy called as a dark field microscopy. Dark field microscopy. Okay, dark field microscopy. Now these spirochetes, they are going to, they are spiral shaped organisms, right? Now whenever they are moving, they will be having a special kind of motility which is called as a corkscrew motility. Okay, corkscrew. Okay, they are going to have corkscrew motility. Now these are some important points regarding the tertiary syphilis or generally syphilis. Now aortic dissection, there is a condition called as aortic dissection. Now what exactly is aortic dissection? I hope most of you guys already know this. Now for example, let me show you. This is the aorta. Okay, this is the lumen of the aorta. Okay, this is the lumen of the aorta, and this is the wall of the aorta, which I am showing you. Okay, this is the wall of the aorta. Okay, this is the wall, entire thing is the wall, and here is the lumen. Now what happens in aortic dissection is that now the blood, see there is an intimal tear, there will be a tear over here. Now the intima is going to be teared. So blood is now passing in the wall of the aorta, now dissecting the aortic valve into two layers, and again the blood flow will again come back. Okay, so what is happening now? The aortic valve is getting dissected with a jet of blood flow. So this is called as aortic dissection. So aortic dissection, why we are discussing here? Why? Because see, we are all discussing about some important points about aorta. Aortic dissection is the most common cause of death in Marfan syndrome. There is a disease called as Marfan syndrome, which is a connective tissue disorder, which is a connective tissue disorder where there is a defective fibrillin protein, okay, Marfan, F for fibrillin defect, okay, Marfan syndrome, fibrillin defect. So it's a connective tissue disorder. The connective tissues are not properly made, so connective tissues are not proper, so automatically the wall, in the aortic wall there are a lot of connective tissues, so connective tissues in the aortic wall are also not proper. Aorta is having lots and lots of pressure. Now what happens is there will be an intimal tear which is going to dissect the aortic wall into 2 layers. Okay, so that is the important point about the aortic dissection, the most common cause of death in Marfan syndrome. And bicuspid aortic valve, usually aortic valve, they are the semilunar valves, okay, they are the semilunar valves. Now they are going to have actually 3 valves, but if they are only having 2 valves, means that is called as a bicuspid aortic valve. Now bicuspid aortic valve is going to be the most common cardiac anomaly in Turner syndrome. See, in Turner syndrome what is the problem? The female, okay, the female is going to have 45X0, means 1 X chromosome is missing. Whenever she is missing 1 X chromosome, she is going to have different clinical manifestations, okay, starting from the head to toe. There are lots of clinical manifestation, and one such clinical manifestation, especially with the heart, especially with the aorta, the two, is bicuspid aortic valve. Okay, the aortic valve is now bicuspid in nature, and that is the most common cardiac anomaly in Turner syndrome. Okay, now after aorta, now let's discuss important points about the arterioles. Okay, important points about the arterioles. Already I have explained to you that arterioles are the blood vessels which are having the maximum amount of smooth muscles. If this is an arteriole, it is having maximum amount of smooth muscle around it. Just like terminal bronchioles. Whenever I am discussing the respiratory system, there I will say the terminal bronchioles are the terminal bronchioles are the part of respiratory tract where there is a lot of smooth muscle around the bronchioles. Terminal bronchioles. Okay. Now in the same way, arterioles, okay, they have maximum smooth muscle around them. Whenever they are having maximum smooth muscle around them, so they can undergo vasoconstriction or vasodilation. I should say arterioconstriction or arteriolodilation can be possible. So whenever there is arterioconstriction, it increases the total peripheral vascular resistance. Whenever there is an arteriolodilation, that decreases the total peripheral vascular resistance. So what I am saying is, arterioles are the blood vessels which have the maximum smooth muscle. Okay, which have the maximum smooth muscle, shows maximum peripheral vascular resistance. So as they are maintaining the resistance of the blood vessels, so these blood vessels are called as a resistant blood vessels. Okay, these blood vessels are also called as the resistance blood vessels. Okay, now arterioles, already I have discussed with you, arterioles whenever they are dilated, total peripheral vascular resistance decreases. Whenever the arterioles are constricted, total peripheral vascular resistance increases. Okay, increases. So afterload, AL means afterload. So total peripheral vascular resistance increases means afterload increases. Total peripheral vascular resistance decreases means automatically afterload decreases. So what is afterload? Afterload is a load against which the heart is contracting. That is nothing but the pressure in the aorta. Okay, aortic pressures. Now after this, let's discuss some important points regarding the capillaries. How exchange of gases or how exchange of materials happens at the level of capillaries. Same, this is the arterial end of the capillary. Okay, this is the arterial side of the capillary or the starting part of the capillary. This is the middle of the capillary and this is the venous side of the capillary. Just a small mistake here, this is not mid capillary, this is the venous side. Okay, that's the venous side of the capillary. Okay, now important point which I want you to know is, sir, please concentrate, let's start from here. In the starting part of the capillary, see, there are two important pressures present. What are the two important pressures present? The two important pressures are hydrostatic pressure. So in the starting part of the capillary, the hydrostatic pressure is 35 mm Hg. Now what is the what is the nature of hydrostatic pressure? Hydrostatic pressure all the time lets the fluid to filter, it allows the fluid to filter out of the blood vessels. Okay, hydrostatic pressure all the time wants the fluid to go out of the blood vessels. And there is also one more pressure which is present at the arterial end of the capillaries. The other pressure is the osmotic pressure, the colloidal osmotic pressure. So colloidal osmotic pressure is mainly because of the albumins, and the colloidal osmotic pressure, what it will do, it all the time attracts the water molecules. It wants to keep the water molecules within the blood vessel itself. Okay, this albumin molecule, they are just like a sponge pieces which are all the time trying to attract the water molecules, not letting the water molecules to escape into the interstitial space. So what I am saying is, sir, at the arterial end of the capillaries, there are two pressures present. The one pressure is capillary hydrostatic pressure, which is 35 mmHg, and the osmotic pressure is 25 mmHg. So what is the difference? The difference is 10 mmHg, 10 mmHg. Who is more? Hydrostatic pressure is greater than the osmotic pressure. As the hydrostatic pressure is more here, what happens? Fluid is going to filter, filtration is happening. Now the plasma is getting filtered. Now the fluid is moving to the tissues. Fluid is moving into the tissues. But do you want the fluid in the tissues? No. Where do you want the fluid? You want the fluid in the blood. So all the fluid is coming into the tissues. Now in the plasma the fluid, in the plasma glucose is there, nutrients are there, enzymes are there, so many things are there, hormones are there, so many things are there. Okay. Now at the end of the day, you want to get the fluid back into the blood vessel. So what happens at the capillary end? What happens? See, a reabsorption of the fluid is happening. Why, sir? Why? Why? Because the fluid re-enters into the capillary. Since the capillary hydrostatic pressure, how much is the capillary hydrostatic pressure? The capillary hydrostatic pressure is just now 18. In the beginning it is 35. Fluid gone out. So what happens to the hydrostatic pressure? It became 18 only. And what about the colloidal osmotic pressure? The colloidal osmotic pressure is now 25. Okay, who is more? The colloidal osmotic pressure is more than the hydrostatic pressure. So now what it will do? It will attract the water. It will try to bring the water back into the blood vessel. So whatever the fluid going out is the same fluid is now again getting reabsorbed back into the capillary at the venous end, at the venous side. At the venous side, the fluid is getting reabsorbed back. Okay, so these forces, the two important forces, the hydrostatic pressure and the colloidal osmotic pressure, now they are antagonizing each other, letting the fluid sometimes out and letting the fluid again back into the capillary. So these are the Starling laws of forces. Okay, these forces are called as the Starling laws of forces, hydrostatic pressure as well as the colloidal osmotic pressure. Now, so what is the conclusion? The conclusion is in the beginning of the capillary, hydrostatic pressure is greater than the oncotic pressure. Okay, or the osmotic pressure. So fluid moves out. At the end part of the capillary, the hydrostatic pressure is less than the oncotic pressure or the osmotic pressure. So what happens? Fluid is going to move back into the blood vessels. Fluid re-enters into the blood vessel. Now, after this, let's discuss about some important special blood vessels which are called as the lymphatics. Okay, so what are these lymphatics? See, sometimes whatever the fluid going into the tissues, for example, if 100 ml of fluid goes into the tissues, do you think all the 100 ml will be properly reabsorbed back into the capillaries? No, it's not going to happen. So some amount, for example 10 ml or 20 ml is going to left in the tissue itself. But do you want that extra fluid to live in the to present inside the tissues? No, we don't want that extra fluid to present inside the tissues. So what we have to do? The nature has created some extra pathway. Okay, so to reabsorb all the leftover fluid. So those channels are called as the lymphatics. Now what these lymphatics are doing, please concentrate. See, here are the capillaries. So here the fluid is going to be leaked, right? Here the fluid is going to be leaked. So all that leftover fluid, see the leftover fluid from the tissues, are going to now enter into the lymphatic blood vessels. See these green blood vessels. If any fluid is left over in the tissues, all that extra fluid will be collected back into the lymphatics, and all these lymphatics are again going to drain back into the venous system. So, lymphatics, any fluid left in the tissues will be brought back into the veins via the lymphatics. For example, if you block this blood vessel, lymphatic blood vessel, now what happens? Do you think that extra blood vessel, that extra fluid which is there in the tissues, is it going to be reabsorbed? No. So, lymphatic obstruction will cause lymphedema and lymphangitis. For example, you can see clearly here in this condition, the patient is having lymphedema. Okay, the patient is suffering with filariasis. The person is suffering with a disease called as the filariasis. In filariasis, these lymphatics will be obstructed because of lymphangitis and lymphedema. Now, these lymphatics will be obstructed. Whenever there is obstruction of lymphatics, fluid is going to accumulate inside the tissue. So, the patient is going to have now this edematous extremities. Okay, these are all the important points regarding the lymphatics. And what is the treatment of filariasis? I recently asked MCQ. The treatment of filariasis is a diethylcarbamazine. Diethylcarbamazine is a drug which is used to treat the filariasis, as well as you can use the albendazole. So albendazole and diethylcarbamazine are the drugs used to treat the filariasis. Okay, now let's discuss about veins. Now veins contain almost 55% of the blood volume. Okay, out of all the total blood volume, see the majority of the amount of blood, that is 55% of the blood is present in the veins. So veins are having a lot of capacity to hold the blood. So these blood vessels are called as a capacitance blood vessels. Veins are also called as capacitance blood vessels, but don't forget arterioles are called as resistance blood vessels. They control the arteriolar dilation, arteriolar constriction. So they are also controlling the total peripheral vascular resistance. What? Arterioles. In the same way, veins are called as a capacitance blood vessels. They have almost 55% of the blood volume. Now, veins are having the maximum diameter. Okay, they are having the maximum diameter. Okay, the diameter is very much more. The walls of the veins are very thin, but the diameter is very much more. The maximum diameter is present for the veins, and the veins contain valves. Inside the veins, okay, inside the veins, they have valves. Okay, not the wall, valves. So which will prevent the regurgitation, or which will prevent the backflow of the blood. Okay, so in order to have the unidirectional flow of blood, veins contain valves. Even lymphatic contain valves. Okay, the lymphatic blood vessels contain valves as well as the veins contain valves. And what exactly is this AV anastomosis? So if you look at here, normally artery, arteriole, here are the capillaries present, here are the capillaries present. So this is something normal. Okay, you'll be having artery is going to divide into arterioles, arterioles into meta-arterioles, meta-arterioles into capillaries. Okay, capillaries is going to now again merge into the venules, veins, vena cava, something like that. This is something normal. But there are certain places in your body where the directly artery is now meeting with the vein. Artery is now anastomosing with the vein, which is called as the arteriovenous anastomosis. So arteriovenous anastomosis is present in certain important places of your body, which includes the fingertips, ear lobules. Okay, in the fingertips and ear lobules, you are having arteriovenous anastomosis. Now, what is the importance of arteriovenous anastomosis? They will regulate the blood, they will regulate the body temperature. So importance about the AV anastomosis is thermoregulation. Okay, they will help in maintaining the body temperature. Okay, that is an important point which I wanted to know. And the clinical link. See here, some important point I want you to know is, so osmotic pressure is mainly due to albumin. Already we have discussed hydrostatic pressure and as well as the osmotic pressure. Osmotic pressure is mainly because of what? Osmotic pressure is mainly because of the albumin. For example, whenever you are having a liver failure or whenever you are having kidney failure, in both these conditions, either there is no production of albumin, in liver failure there is no production of albumin, or whenever you are having a nephrotic syndromes, the kidney problems, lots of albumin is going out in the urine, so proteinuria is there. So in both the conditions, the patient is losing the albumin. Okay, in the first condition, there is no production of albumin. In the second condition, there is loss of albumin from the body. So what happened to the osmotic pressure? The osmotic pressure goes down. When the osmotic pressure goes down, the hydrostatic pressure is going to be will be more. Okay, relatively the hydrostatic pressure will be more when compared to the osmotic pressure. Now what happens? Now the fluid is going to come into the tissues and to the interstitial space, causing edema. So the clinical link which I want you to know is, so loss of albumin in the urine will cause a decrease in the osmotic pressure in the blood vessel. So edema will occur. So whenever there is edema in the body, what you have to use? Okay, especially if there is pulmonary edema, you have to use drugs like loop diuretics. So loop diuretics means what? They will increase the urination. So diuresis, they are causing the diuresis, increase the urination. So more amount of fluids are taken out of the body. So extra fluid, whatever is accumulated in the body, all that extra fluid is now going in the form of urine. So edema is treated. Okay, so with this we have discussed important points in the vascular physiology. We have discussed important points about the important blood vessels like aorta, arterioles, capillaries, lymphatics, okay, veins. So all the important points are done. In the next video, let's discuss about hemodynamics. Hope the video is helpful. Thank you.